Okay, so we're going to get started. Welcome everyone to the Global Leaders in Implementation Science seminar series. My name is Guillaume Fontaine. I'm an assistant professor of implementation science at the Ingram School of Nursing at McGill University. And this seminar series is organized by the Ingram School of Nursing and the RISE Lab at McGill. And it's going to be occurring over the course of this year. So we're going to have 6 seminars with leaders in implementation science, sharing insights on emerging trends, innovations in the field, but also practical insights on how to improve implementation practice, implementation research. And the goal of this series is really to be able to engage with thought leaders at the forefront of the field, and to have some interesting discussions linked with presentations. So I'm going to say as well that the questions are going to be going through the Q&A functionality of the webinar. So you'll see that there's a Q&A section on Teams. So if you have any questions during the presentation of Dr. Powell, you can put your question in the chat, and I'm going to be getting at those questions at the end of the presentation. So we're going to have around a 50-minute presentation, or around this, or a bit shorter, and then we're going to go into the Q&A section. So without further ado, I'm pleased to introduce Dr. Byron Powell, who is a leading expert in implementation research and practice. Dr. Powell is an associate professor and associate dean for research at Washington University, the Brown School specifically, where he co-directs multiple centers dedicated to mental health services, dissemination, implementation science. He also holds a number of appointments and adjunct roles at UNC Chapel Hill, UNSW Sydney, and University College Cork. Dr. Powell's work, primarily funded by the US NIH, focuses on advancing methods to improve the quality of health and social services. He has over 160 publications, co-edited 2 books, is recognized as a Clarivate Highly Cited Researcher, and among the Stanford-Elsevier World's top 2 scientists. His contributions have earned him numerous awards, including the Early Career Award from the Association of Behavioral and Cognitive Therapies, a Fulbright Specialist Award, and also Washington University's Provost Research Excellence Award. He also serves as co-editor-in-chief of Implementation Research and Practice, and on the editorial board of Implementation Science. He has played a leadership role in the Society for Implementation Research and Collaboration as its past president from 2020 to 2023. And he's really committed, and we can see globally, to building capacity in implementation science. He is really the core faculty for multiple international training initiatives in implementation science. So today he'll be sharing insights into his cutting-edge work on developing and evaluating implementation strategies to improve health and social services. So please join me in welcoming Dr. Byron Powell. Byron, the stage is yours.
Thank you so much, Guillaume, for the warm welcome, and thank you for the opportunity to be here. I'm delighted to share some of our work with you today, and I'm also delighted that we'll have plenty of time for discussion. So thank you so much for creating this opportunity in this series. The lineup looks spectacular, so I'm looking forward to joining the other talks as well. So I really appreciate the opportunity today. So I'm going to start off with just a bit of an overview to my journey to implementation science, and then I'm going to spend the bulk of the time talking about some of our work to understand implementation determinants, to identify and classify implementation strategies, and then I'll move into discussions about how we might improve designing and tailoring implementation strategies, and specifying and testing mechanisms of change for implementation strategies, and we'll conclude with just a few slides on thoughts about improving the tracking and reporting of implementation strategies so that we can improve the replicability of our work. My path to research, just briefly, I never intended to be an academic or a researcher. I actually started my career hoping to be a high school basketball coach and a school social worker. And in the course of my early work in child and adolescent mental health and in social work, I became very interested in evidence-based practice and how we might move that into routine care. And my career started in working in a group home for adolescent males just west of Chicago in the States, and worked for I think, forward-looking organization that was concerned with how do we better integrate evidence-based practices and principles in our work. And even in partnering with a local university, we found numerous challenges to actually implementing evidence-based practices. And this started with staff and my colleagues suggesting that we're maybe not well prepared to deliver these practices. We're not trained. We don't have the credentials. There were also, I think, a number of other organizational barriers to implementing evidence-based practice that I began to see just sort of in practice. But I continued this interest, and as I pursued further education in the field, I transferred to the University of Chicago, where I finished my master's in clinical social work. I got really interested in the evidence-based practice process, wherein clinicians were supposed to be assessing the evidence, integrating that with patient values and their own expertise. And I also became quite interested in a number of specific evidence-based interventions in mental health and behavioral health. But again, as I sort of proceeded in my clinical practicums in a psychiatric hospital and in school of social work, I found that these evidence-based practice principles, the process, and these specific interventions weren't necessarily being readily implemented, and again saw practically just a number of barriers to implementation. And in fact, this continued as I had my first job out of my master's program in a residential care facility. Again, I think offering great quality of care, but in many ways not necessarily driven by the best available evidence and an effort to integrate evidence-based practices. So I was eventually driven to pursue a PhD in social work and mental health services research. This was before implementation science was a formal offering in terms of the training, but was fortunate to end up at Washington University in St. Louis, where a number of folks were focusing on implementation science, and been working in this area ever since. And just broadly, my research agenda has focused on identifying implementation determinants. So how can we better anticipate and assess barriers and facilitators to implementation? How can we, it's also focused on implementation strategies. How can we address barriers and facilitators and move effective practices into routine care? And a lot of my work and our work has focused on implementation methods. So developing or applying pragmatic methods and tools to support implementation. So I'm not going to spend a lot of time on the front end of this, but just to say some of my earliest work in the field was actually to conduct, qualitative, quantitative, and mixed methods studies of implementation determinants or barriers and facilitators to implementation. And so, for instance, working in child and adolescent mental health, some of my first studies were, a qualitative study of practitioners' experiences of implementing evidence-based practices. What were some of the facilitators? What were the barriers to actually carrying out that work? Also, a quantitative study that involved a survey of clinicians who were engaged in a practice-based research network to assess what made them more or less willing to engage in evidence-based practice training. Moving on, as I pursued a postdoc at the University of Pennsylvania and the Department of Behavioral Health in Philadelphia, conducted a number of studies in collaboration with Renad Betas and colleagues, focusing on barriers and facilitators to policy-focused implementation efforts in Philadelphia. And this one example early on was identifying and prioritizing barriers related to HIV implementation work in Nigeria. Increasingly, this work has also involved the integration of theories and frameworks. If you're new to this field, you'll see that we sometimes have an overwhelming number of theories and frameworks, but work to understand barriers and facilitators in this field have been, I think, usefully guided by some of these frameworks, such as the theoretical domains framework, the consolidated framework for implementation research, and others. One sort of practical example of this that has guided some of our work in Philadelphia is a policy ecology framework, which is really sort of a simple ecological framework developed by Ramesh Raghavan and colleagues. And in this case, this simple framework really guided our understanding of Philadelphia's implementation efforts related to evidence-based practice in behavioral health. Oftentimes, we're focused on this center circle, the clinical encounter between, say, a therapist and a patient. But we know the implementation of evidence-based practice is highly influenced by things like the organizational context, the regulatory and purchasing agency context, the broader political context, and certainly the social context, things like mental health stigma. And so we were able to show in a 2016 paper how these different levels and specifically barriers and facilitators at this level, at these levels, were addressed by thoughtful implementation strategies and interventions by the Department of Behavioral Health in Philadelphia. So provide sort of an example of how some of these frameworks can be useful in guiding our assessments of barriers and facilitators. We've also been interested in methodological development. So this is work in collaboration with Kara Lewis and Brian Weiner and other colleagues, where we've been interested in looking at the measurement, the state of measurement and implementation. And in this broader study, we looked at measures related to the 39 constructs of the Consolidated Framework for Implementation Research, as well as the 8 implementation outcomes that Enola Proctor and colleagues have identified. And we assessed the psychometric evidence for these measures, as well as, in some cases, the pragmatic evidence for these measures. So sometimes measures are actually quite psychometrically strong, but they're expensive, they're lengthy, they're difficult to administer and score. And so they're not very pragmatic to guide implementation research and implementation practice. And so would direct you to the link at the bottom of this slide if you're interested in a special collection published in Implementation Research and Practice that highlights a suite of papers identifying those psychometric properties for a number of constructs that might be of interest to you all. And finally, as we think about identifying and prioritizing barriers and in the field, we've increasingly been using community-based participatory methods for this. Certainly a variety of methods can be brought to bear to understand barriers and facilitators, and indeed perhaps understand better the complex relationships between them. So in this case, this is a study led by Gaurav Dave and Giselle Corby-Smith in North Carolina, where they used both concept mapping which is a structured sorting and rating process that is used in this case to identify and prioritize various barriers to implementing a cardiovascular intervention in rural African American communities. We also then used a method called group model building, which is drawn from the system science field to understand the complex relationships between these various barriers to implementing effective practices. And later on in the presentation, I'll share some work from Gracelyn Cruden that's sort of really, I think, helped us to contextualize that within the field of implementation science. So I know I'm moving quickly, but moving quickly to identifying and classifying implementation strategies. And just to sort of level set at the beginning here, we've defined implementation strategies as methods or techniques used to enhance the adoption, implementation, sustainment, and scale up of a program or practice. These are essentially interventions for our evidence-based interventions to move them into usual care. And in our work, we often refer to discrete strategies, which arguably involve a single action or process. Though admittedly, these what we sometimes refer to as discrete strategies are undoubtedly complex interventions in and of themselves. But examples of this include things like clinical reminders in an electronic medical record, audit and feedback, where we may measure performance and feed it back to providers in comparison to their peers. Or in mental health, for instance, often clinical supervision is a common implementation strategy. Oftentimes in implementation, we're dealing with complex interventions. We're dealing with a myriad of barriers and facilitators that may need to be addressed or leveraged. And so oftentimes multifaceted strategies or implementation interventions are necessary. And these combine multiple discrete strategies, hopefully in ways that are synergistic, such that 2 + 2 = 5 instead of 4, that they're well matched to barriers of interest, and that they work together well in concert. Just one example of that is taken from some work by my colleague Sam Schilling, who's a child abuse pediatrician and primary care doc in North Carolina. Sam has an evidence-based intervention called PriCare, which is an evidence-based child maltreatment prevention, obviously delivered in primary care. And Sam basically was approaching a particular challenge related to referrals to PriCare. So she had this effective intervention, but she said, you know what, physicians just aren't actually referring to this intervention. And so this might not be sort of a traditional implementation outcome that you might think of, but this green oval represents really her target is referrals to PriCare. The rectangular boxes that you see are examples of implementation strategies. And this was her effort to sort of design a strategy that was hopefully synergistic, that worked to improve referrals to care. So in this case, she used public recognition, so really giving physicians kudos and maybe even a small token of appreciation, like a $5 Starbucks gift card, which I think doesn't buy you a cup of coffee anymore. In conjunction with parent narratives, so parents who had gone through the intervention and could speak to its merits. Hopefully, these two implementation strategies she hypothesized would work in an accumulative fashion to address clinician motivation to refer. She also engaged in audit and feedback, so measuring referral rates and feeding that back to physicians, hoping that would amplify the effect of those other two strategies on clinician motivation. She prepared potential parents to be potential participants in this intervention by pushing out MyChart notifications to parents that describe the intervention and hopefully improve their motivation to engage in the intervention, or at least in discussions about it. She hoped that these strategies would converge, that the improving clinician motivation and parent motivation would converge to increase referrals to PriCare. And then finally, she used one additional implementation strategy, which was a reminder in the electronic medical record for clinicians to refer to this practice. And she was able to show this was basically using a quality improvement design. So this wasn't an RCT. She was able to increase referrals from 13% to 55%. So was quite pleased with that. And the link, the reference to Sam's work below, I would urge you to take a look at if you want to read more about this study. But also, I think Sam does an excellent job of presenting sort of the theoretical, empirical, and pragmatic justification for why each of these implementation strategies was selected. And obviously here, trying to show how she thinks they fit together to improve referrals to PriCare. So some of our earliest work in the field was actually to simply identify implementation strategies. And this was initially driven by the question, what are effective or evidence-based implementation strategies? And when we went to the literature, we found what's been referred to as the Tower of Babel problem, that sometimes the same implementation strategy term was used to describe completely different strategies. Different terms were used to basically describe the same strategy, and that the language was really inconsistent in the field. And so drawing upon a review of the health and mental health literature, we thought a useful first step was simply naming and defining implementation strategies. So this paper on the left represents our first effort to do that, where we named and defined 68 discrete implementation strategies, and we grouped them into 6 categories that made sense to us, not using a specific research method to identify those categories. we thought that was a good initial step to give just a common vocabulary to the field, hopefully provide some sense of the potential options for implementing effective practices across research and practice efforts. We were then fortunate to be approached by some colleagues from the Department of Veterans Affairs in the US who engaged with us in this study that's called the Expert Recommendations for Implementing Change, or the ERIC study, where we engaged in a Delphi process and then a concept mapping study, first to vet these terms and definitions by experts in implementation research and practice, and then to empirically derive conceptually distinct categories of these implementation strategies, as well as ratings of their importance and feasibility. And I won't dwell on this too much. This is sort of an overview of the 9 categories that we identified in this study. And ultimately, we refined this compilation, and it resulted in 73 discrete implementation strategies. I often say sometimes the good stuff in implementation science articles is buried in additional files. And so would point you to additional file 6 of that 2015 paper below for detailed definitions of these implementation strategies, as well as some ancillary material that might help further contextualize the strategies. Obviously, this is now about 10 years old, and so this is, again, a start, but definitely not the be-all, end-all. We hope that this compilation serves a purpose for the field in identifying building blocks of multi-level, multifaceted strategies for research and practice. Again, that it can help promote a common language and improve reporting in the field, but plenty of room for critique, dialogue, and ongoing refinement. And I'll share some of the ways in which we're trying to do that in our work, and potentially there are many opportunities to continue that moving forward. We've been pleased to see this picked up in the U.S. By some of our key funders and federal institutes, as well as increasing use internationally. But again, even more excited about ways in which colleagues and others are really refining this work over time. I know this is a ridiculous number of of papers on a slide, but wanted to shout out the work of Sherry Rogao, Very Yakovchenko, and colleagues, Matt Shinman and others at the University of Pittsburgh, who have really taken some of the application of this ERIC implementation strategy compilation to the next level. So they've turned this into a survey that they've been using to either retrospectively or prospectively track the use of implementation strategies in national evaluations within the VA. So the red box is around some of the survey refinement work that they've done here in the bottom left. And a number of these top papers represent some of those national evaluations that have tracked this longitudinally. They've also used some interesting methods that I won't get into in much detail, but wanted to call out for this group. So they've used methods called configurational comparative methods, which are really driven by this notion of equifinality, such that there's more than one way to be successful in implementation. So what this set of methods does is it allows us to identify implementation strategies that are both necessary and sufficient in achieving our outcomes of interest. And so in those two papers on the bottom right, identify strategies or sort of different pathways of strategies that were successful in implementing, in this case, Hep C treatment starts and improved care for cirrhosis within the VHA. Though we meant this compilation to be relatively generic and hopefully is useful and relevant to the areas that many of you are working in, we've also had colleagues that have meaningfully, I think, extended this work for specific areas. So Clay Cook and colleagues have extended this work for school mental health. We've had colleagues, Andrea Graham and colleagues at Northwestern have tried to examine how these strategies are relevant within digital mental health care interventions in healthcare settings. Alex Dopp and colleagues have identified in addition to the many financing strategies identified through the ERIC compilation, have extended that work through identifying financing strategies in behavioral health. And we've also been asking other questions about sort of the similarities and differences between implementation strategies and strategies for other outcomes like sustainment and de-implementation. So first, are these strategies relevant to sustaining implementations, sustaining interventions over time? And Nicole Nathan led this review in which, this refinement effort in which we were able to both sort of contextualize the implementation, the ERIC implementation strategies in terms of their relevance for sustainment, but also I think usefully identify the specific phases in which those strategies are most relevant potentially. And that might not be a perfect categorization, but I think can help you to consider what strategies might be relevant at different stages. Similarly, we've been asking questions about how do these strategies potentially help us to de-implement interventions that are no longer helpful and might even be harmful. In this review, Sarah Ingvarsson has basically used the ERIC compilation to code de-implementation interventions and found that largely there's overlap, that the ERIC compilation was successful in categorizing those implementation strategies and was useful on that front. There's also work that I want to point out by Andrea Patey and colleagues that has done this with behavior change techniques to see what's sort of similar and different between implementation and de-implementation studies and the types of behavior change techniques that are needed to accomplish those goals. One of the major critiques of the ERIC compilation has been it was really developed using, in addition to the literature review, using experts to refine the compilation from primarily North America, US, and really just a smattering from Canada. So definitely legitimate questions about how does this apply internationally, how does it apply in low and middle income countries and the like. My colleague Kate Livero at Columbia has led recently a systematic review of the use of this compilation internationally and specifically in LMICs, and has found increased usage of this over time and I think a lot of relevance. Although certainly opportunities to potentially extend or strategies that are not as great of a fit potentially internationally. We've also Elvin Gang and Ingrid Eschen-Wilson and colleagues have conducted a living meta-analysis of implementation strategies in LMICs related to HIV implementation studies. And one of the things that they found was that they were able to categorize many of these implementation strategies used in those settings using both the ERIC compilation and something called the Cochrane Effective Practice and Organization of Care taxonomy. But they found that sort of patient-focused implementation strategies were often ill-fitting with both of those compilations. And so a lot of the more patient-focused strategies potentially not necessarily showing up in those taxonomies, again, suggesting opportunities for refinement. And then lastly, we've been pleased to see the ERIC compilation translated into German, Spanish, and Japanese, and hopefully we can see additional translations over time that will hopefully increase relevance and also allow us to sort of pressure test this compilation over time. I mentioned briefly behavior change techniques. Many of you may be familiar with the behavior change techniques that Susan Mickey and colleagues have developed, which are represented on this paper on the left. I also include this bottom link to the Human Behavior Change Project, where they've really expanded this into a behavior change technique ontology. It's really wonderful work that I would say describes interventions and implementation strategies in a much more granular way than we do in the ERIC compilation. So we actually see these things as potentially complementary. So Sheena McHugh at the University College Cork in Ireland has written this paper a couple years ago where we examined the complementarity between the ERIC compilation and the behavior change techniques. And oftentimes we found that, even a strategy like audit and feedback could be represented with a variety of different behavior change techniques. And so we found that sometimes the broader definition as provided in the ERIC compilation could be operationalized further by specifying the specific BCTs that are involved. And so would urge you to take a look at that paper if you're interested in sort of how they may fit together usefully. So having shared some work to I think better identify and characterize implementation strategies, I just wanted to include a few slides pointing to the evidence for implementation strategies. And on this slide, many of these reviews are drawn from the Cochrane Collaboration's Effective Practice and Organization of Care group, which many of you may be familiar with. I'll also note that likely several of these reviews are due to be updated or have been updated. So for instance, I know the audit and feedback review is I think currently under review at Cochrane and has identified even more RCTs. Don't quote me, but I think over 500. Guillaume, you might actually be involved in that work and know. So feel free to put it in the chat if anyone's involved in that. I've been involved with the tailoring interventions Cochrane review led by Sheena McHugh, and I think we've identified at least 3 times as many randomized trials in that review. So evidence is accumulating. Oftentimes the effect sizes are small to moderate for these implementation strategies, but we have a lot of evidence to support the use of various implementation strategies, and I think we'll talk much more as I proceed about how we can perhaps improve the evidence over time. I won't go into the minutiae here, but since I ranted for a good chunk of time about the expert recommendations for implementing change compilation, this recent paper by Laura Ellen Ashcraft and colleagues uses the ERIC compilation to assess the evidence in implementation trials within the US. And so you might be interested in taking a look at that and specific strategies that were evaluated in that study. And then this gets quite meta. This is work led by Annette Boas and colleagues, which explored 86 systematic reviews of different types of implementation strategies, including those from LMICs. And some of their conclusions emphasized first that the impact on implementation strategies, that the impact of implementation strategies is often small to moderate, and mainly on processes of care. So for instance, can we get health professionals to change their behavior, change prescribing, change other behaviors of interest? That context is key, which shouldn't be a surprise to those who are interested in implementation science. But there's a note that this information has traditionally been omitted from studies and certainly reviews. And they conclude by noting that what is needed isn't more reviews or reviews of reviews, but really research to explore the situated, relational, and organizational nature of evidence-informed practice. And I'm going to say more about that moving forward. But I think this is really a signal that we need to focus more on how and why implementation strategies work, and thinking through things like the mechanisms through which they work, rather than just whether or not they work. And so we'll share more about that as we proceed today. This is in fact actually one example that I wanted to point you to that really focuses on sort of what works under what conditions and for whom. And I realize that on this screen, this might look like spaghetti to you. It might be overwhelming. You're not necessarily intended to take this all in right here, but this is a realist review by Singh and colleagues about how pay for performance might work in low and middle income countries. And what I really appreciated about this review was that they use this system science-based method, causal loop diagramming, where they can depict feedback loops, reinforcing loops, and balancing loops, to sort of depict sort of the complexity of these types of changes. But they were able to identify what's sort of their initial program theory for how pay for performance works, and then after conducting the review, they were able to revise their theory. And what you see in green here are the pathways that were common to both their initial and revised program theory. But I think this represents both trying to push the evidence to sort of a more contextual space, what works for whom under what conditions, but also is a nice example of theorizing and sort of iterative development of theory over time in the implementation space. So just wanted to highlight that as a potentially useful paper if you have a chance to take a look. So I'm going to move on here to really selecting, designing, or tailoring implementation strategies. And this is perhaps I've been using this slide for too long, but leave it in there because it usually resonates with at least some people. And so if I had more time, I would ask you sort of, how do you usually go about selecting implementation strategies? And depending on the audience, I usually get a variety of answers that vary with respect to sort of the rigor and maybe how systematic they are. But oftentimes I also see these sort of potential pitfalls that we face in designing and tailoring strategies. One is that we rely too much on sort of a train and pray or train and hope approach, right? So perhaps too much focus on educational implementation strategies, hoping that behavior will change, but we know that that's really necessary, but often not sufficient, given that there are a number of other challenges related to implementation that need to be addressed. We often see also sort of an organizational inertia or a system inertia where you might sort of see things like, we've always done it this way. We always use this particular strategy, whether that's a plan, do, study, act cycle, a learning collaborative, training, whatever that might be. We often get into a rut and sort of potentially use the same implementation strategies all over. Maybe one example of that that I've heard now in a few places is that sometimes healthcare administrators say, when I want to implement a new thing, I send an email in the morning and then it gets implemented. That's how they think things, how implementation works. I think many of you will recognize that that's not sufficient. I'm not always sure how this expression translates, but we often may fall prey to sort of a kitchen sink approach. This idea that more is better in implementation strategies. That given that we face a variety of barriers to change, that more intensive implementation strategies are likely to be more effective. And in fact, this is work by Janet Squires and colleagues. They show that simply adding, a number to an implementation, an additional component to an implementation strategy doesn't necessarily make it more effective. And that might be puzzling to us. And I think there are, potentially a variety of reasons for this. One, we can talk about sometimes simply there isn't a very good match between the types of implementation strategies we use and the types of barriers and facilitators that we're facing. Other times there may be sort of a multifaceted strategy, but it really addresses only one level. So you could imagine strategies that all focus on provider level barriers, but maybe neglect organizational, systemic, patient level barriers that may be really driving implementation problems. Some of our work has been really interested in and really focused on how do we better tailor implementation strategies to the unique needs of different sites. And so arguably we too often use a one-size-fits-all approach to implementation when we know that different individuals, different sites, different regions may need very different implementation strategies. I will say that this is maybe a bit more controversial and muddy area of the literature, which we can certainly talk more about. And then finally, Martin Eccles, who's one of the founding editors of our journal, the journal Implementation Science, noted that we too often use the Islagiat approach. It seemed like a good idea at the time. And this really results in what Michel Vensing and Richard Grohl have suggested, is that there's often little association between the type of problems that we face and the approaches to change taken. And they also note this issue that organizational and system-related problems tend to be ignored, often in favor of individual educational and psychological approaches, again, more akin to train and pray. And so we think there are a number of opportunities to improve and enhance the effectiveness of implementation strategies. I'm going to focus on these first three today. So enhancing methods for designing and tailoring implementation strategies, specifying and testing mechanisms of change, and improving tracking and reporting of implementation strategies. Hopefully throughout this series and other opportunities, you'll learn more about conducting implementation trials, as well as increasing economic evaluations of implementation strategies, which I think are really important priorities for our field. So to start off with, there's some evidence that suggests that actually tailoring implementation strategies to prospectively identified barriers to change leads to more effective implementation. Although in this review by Baker and colleagues, it's not yet clear how best to tailor implementation strategies, and therefore not clear what the effect of an optimally tailored implementation strategy would be. And that's because oftentimes the methods that people use to design their implementation strategies, to tailor their implementation strategies, are not necessarily rigorously or transparently reported. And so this review is a bit old, but the review I mentioned previously by Sheena McHugh and colleagues is currently, you can see the protocol here, but is also the results of that review are currently under review with the Cochrane collaboration. And in conducting that review, we ran into a number of sort of conceptual and methodological issues as it pertains to tailoring and designing implementation strategies. And so one is simply the definition of tailoring in this case. And so in some literature or in some studies, tailoring is really defined as any approach to prospectively identify implementation barriers and design a strategy that addresses them. In some ways, this seems like just good strategy development, right? That we're thinking about potential challenges, thinking about the implementation problem, and designing a strategy accordingly. In other cases, tailoring actually refers to delivering different implementation strategies depending upon the needs of different individuals, groups, or settings. The level at which implementation tailoring takes place also varies, right? So anything from sort of like personalized medicine approaches that might tailor implementation at an individual level to tailoring based on a team, an organization, a region, etc. There are also questions about the stages or timing of tailoring. And so is it enough to sort of assess implementation determinants and contextual factors at the beginning of a study or implementation effort, design our implementation strategies, and assume that like nothing is going to change, nothing will need to be tweaked along the way? Or do we need to assess barriers in a more longitudinal way and tweak our implementation strategy based upon either new barriers that emerge or even the implementation performance of individuals or organizations? So maybe if individuals are not necessarily implementing well, they may need additional supports or different supports. And so should we be tailoring in that way? And then again, the methods by which people use to do this are not necessarily well reported. And so I think a lot of opportunity for innovation and to use more systematic methods on this front. I'm going to suggest here that I'm going to, I think for the sake of time, fly through many of these methods but I'm going to suggest that as we look through sort of the growing number of potential methods to develop and tailor implementation strategies, they really share these sort of common steps. This is certainly true for a method that I'll share called intervention mapping or implementation mapping, and others. The first step is really to identify who needs to do what differently in order to improve implementation, sustainment, scale up, and the like. The second step is, and actually let me dwell on that for a second. I think oftentimes we overlook, key individuals and groups that are either influencing or influenced by implementation. I think it's really important to consider equity from the outset, and to really think about who needs to be at the table as we think about designing implementation strategies and the like. The second step is really to use informal and formal theory and frameworks to identify barriers and enablers that need to be addressed, and hopefully to articulate a pathway for change for the targeted behavior change to occur. And here I'll just note that a variety of methods can be used, certainly starting with a literature review of implementation determinants is really great given the development of our field. We have a number of studies focusing on barriers and facilitators. Certainly qualitative, quantitative, and mixed methods can be brought to bear. But even sometimes informal consultation with our key partners can be a useful way of identifying potential determinants. We then want to select implementation strategies that hopefully are effective, locally relevant, acceptable, and feasible to overcome these barriers and enhance facilitators to change. And then ultimately decide how that change can be robustly and feasibly measured, including factors along the hypothesized causal pathway, and appropriate implementation outcomes or other proximal, intermediate, or distal outcomes that are of interest to you. We'll share a bit more about that as we get into the mechanisms piece in a few slides. For the sake of time, I won't dwell on this, but just to say this is a really great paper by my colleague Shoba at Harvard, who has identified a number of ways in which participatory implementation science approaches can be useful as we're identifying determinants, thinking about designing and tailoring our implementation strategies, considering potential mechanisms that we might want to identify or test, and considering the types of implementation and other outcomes that we're evaluating. And so highly recommend this paper if you haven't seen it in Annual Review of Public Health. I'm going to skip over this slide as well, but these are resources that talk about potential methods for designing and tailoring implementation strategies, many of which are highlighted on subsequent slides. The first is intervention mapping or implementation mapping. And again, the steps here are quite familiar with the steps I just shared a couple slides ago from French and colleagues that are really, I think, generic and cut across a lot of these different systematic approaches. But I just want to highlight two ways in which we've used intervention mapping, or as it's been rebranded to suit the implementation science literature, implementation mapping. We've used this first to co-create implementation strategies with organizational leaders and clinicians in child and adolescent mental health organizations, with the notion that organizations are all different. They may need unique implementation plans to suit their individual organizational needs and strengths. And so we actually worked with them to go through this process systematically to identify unique implementation plans or blueprints for their site level needs. So that's one way that we've used this more systematic approach. The other sort of common way that we're using this is oftentimes to develop a implementation strategy, oftentimes in the context of grants and proposals where we may have an idea of what the implementation strategy will be, but we need some formative work to really solidify and finalize what that implementation strategy is going to look like. So in this case, we use this within the context of a trial of a systems navigation and psychosocial counseling intervention in Vietnam, where we used intervention mapping to basically develop a standard implementation strategy as well as a menu of tailored implementation strategies or implementation strategies rather, that could be tailored to site-specific needs within this cluster randomized hybrid 3 trial. And the results of that are now under review. But in that study, we found the tailored approach more effective than a standard approach to implementation. And I'll just point out, if you're interested in implementation mapping, we have a recent special collection in Frontiers of Public Health that provides a number of examples of how this can be used to adapt interventions, how it can be used to develop implementation strategies, or even how it can be used to simply design interventions such that they're more implementable and sustainable. There are a number of other approaches available that provide sort of a systematic set of steps that you can follow. One is the evidence-based quality improvement approach, as developed by Jeff Curran and colleagues at the University of Arkansas for Medical Sciences. And what you see here on the slide is a paper from Terrence Swindle. I won't go over the specific steps here, but the reason I have this in here is that as you look at these steps to implementation, you can see that a variety of activities can be brought to use to accomplish these basic steps. And to me, this highlights, again, room for innovation, room for creativity. And as if you look at these specific activities, I think you'll see that some of them vary with respect to sort of how rigorous they are, how potentially evidence or theory driven they are. And so one, I think it's room for creativity, but two, I think it represents an opportunity for us as a field to better test and potentially prioritize the types of methods that are most effective at accomplishing these steps. I think for the sake of time, I can't go into this, but I've mentioned causal loop diagramming and group model building, which is a participatory system dynamics approach. And Gracelyn Cruden has really done a great job of suggesting how group model building can be leveraged to operationalize implementation strategies across implementation phases in this paper. So would urge you to take a look there if you'd like. Similarly, I'm just going to fly through these. This is a method called oilcloth sessions, where sort of Lego-like figurines are used in this case to simulate essentially what implementation of a new emergency department in Denmark will look like. And Jeanette Wasserkirk has done, actually has a number of studies where she's looked at the implementation of these emergency departments. And this is another sort of participatory approach that can be used to simulate or model and simulate change with respect to implementation. We've also developed some other tools. So I mentioned earlier the Consolidated Framework for Implementation Research, which is a common framework for identifying implementation barriers. This is a tool that allows you to essentially identify the types of strategies that are most likely to be helpful in addressing those determinants. And this is based on an expert consensus method, but has also been sort of applied to real-world implementation efforts. This paper referenced by Vera Yakovchenko at the bottom of the slide suggests some evidence that the strategies that would be suggested by this tool were actually effective in a real-world evidence implementation effort. No time for these, but just to say there are a number of other approaches that are being developed and assessed in the field. This is not an inclusive list, but wanted to highlight work from colleagues in this space. I know that Guillaume is going to kick me off the stage relatively quickly, but I want to just highlight this piece about mechanisms and tracking here as we move on. And so again, I think a lot of emphasis in the field is moving away from just simply assessing how and why, whether or not strategies work, to how and why they work. We've defined mechanisms in this space as processes or events through which an implementation strategy operates to affect desired implementation outcomes. These examples are perhaps too simple and maybe imperfect, but just as an example, I picked on training a bit, but if we have a barrier related to a provider skill deficit, it may be that something like training and teaching and practice with corrective feedback is an effective implementation strategy that might operate through the mechanism of skill acquisition, refinement, and mastery, and ultimately lead to providers having improved fidelity to an evidence-based practice. If we have a barrier on a different level related to turnover in a healthcare setting, it may be that a train-the-trainer approach might operate to ensure that real-time training and consultation is available for each site, and improve an implementation outcome that's like sustainment or sustainability. And the idea here is that we'd like to see sort of tight alignment between determinants, strategies, mechanisms, and outcomes, and that this can help us think more systematically about how we design strategies. So a number of ways that sort of shifting our attention to mechanisms in implementation science can help us. This is from a paper from Pedja Klajna and colleagues, where they suggest that understanding mechanisms can really help us to match implementation strategies to identify determinants. It can also help us to understand the conditions under which an implementation strategy will work or not. It can help us to design multifaceted implementation strategies. It can help make our implicit theories, our often implicit ideas about how strategies work, explicit as we develop causal theories of how implementation strategies work. It can help us to measure implementation strategy functioning. So earlier on in the process, thinking about, is a strategy working as it's intended, and if not, do we have time and leeway to tweak the strategy over time? And it can also help us to diagnose why an implementation strategy did not work as intended. So if we end up with null findings from a study and we need to go back to the drawing board, it can help us to not sort of throw the proverbial baby out with the bathwater, and actually think about how might we tweak a given strategy so that it works more effectively. We've been using a variety of methods and processes to sort of depict implementation mechanisms and how and why implementation strategies work. One of those methods is called causal pathway diagramming, and we have a toolkit that's published on this website, impscimethods.org, here at the bottom. And in this process, we've been using this to both identify implementation strategies, but also identify what are the moderators that might influence how the extent to which that implementation strategy is successful, what are the mechanisms through which it operates, what types of determinants is it addressing, and then what are the proximal, intermediate, and distal outcomes that are being addressed here. We also identify sometimes preconditions, which are really moderators, which are so strong so as to be sort of a go or no go for a strategy. Like, it's not going to be successful if this precondition isn't in place. And we have a lot of work to advance the study of mechanisms with respect to that causal pathway diagramming approach. We're building a database of strategy, mechanism linkages, and associated causal pathway diagrams for 30 commonly used implementation strategies. We're developing psychometrically strong and pragmatic measures of mechanisms, and ultimately we'll develop and disseminate a website of that knowledge. And so stay tuned for more on that front. And just want to provide here, I'm hoping that you can see this okay on your screen. Want to provide a practical way in which we can think about mechanisms being helpful. This was work that was really encouraged by a study testing a knowledge brokering implementation strategy to improve evidence-based staffing in hospitals on the weekend. I'm no expert on evidence-based staffing in hospitals, but this was a trial led by Mitchell Sarkis in Australia, and his colleagues ultimately conducted a really nicely conducted trial, but had null results. And when we looked at the paper, we thought it would be really helpful to understand the mechanisms through which knowledge brokering was intended to work. So in this case, using some of their work, their process evaluation, as well as the literature, we suggested that knowledge brokering really works through cultivating a social link. So there's a relational development component wherein, in this case, a knowledge broker works with hospital managers to develop a relationship, to provide brokered knowledge of the evidence. So they package, simplify, and contextualize the evidence for a manager. Hopefully the manager absorbs, understands, and integrates that knowledge, which leads to changes in staffing and ultimately evidence-based staffing. There's also a component in which a knowledge broker facilitates individual and organizational capacity for change, which increases a manager's ability to use and interpret data. Of course, there are a number of contextual elements, or in our other approach to diagramming mechanisms, this would be seen as a moderator. So something like the status of the broker and the positioning of a broker in the organization really matters. And in this study, I believe they used postdocs as the knowledge brokers. And so one could argue that postdocs might not have the relational capital with hospital managers that would be needed for a knowledge broker intervention to be successful. So that's an example of how I think looking at mechanisms might help us to operationalize the implementation strategy differently. It also may help us to measure something like the status of the brokering and the positioning of the brokers within the organization, so that we might understand how that actually influences their effectiveness. And ultimately, in this case, even after a quote-unquote failed trial or a trial with no results, it might help us to understand how we can improve the use of knowledge brokering over time, rather than just rejecting it as a strategy outright. I know we have limited time, so I'm just going to say there are a number of examples, and I'm happy to share these slides so that you can take a look. There are a number of other ways of depicting mechanisms, including causal loop diagrams and system science-based approaches that I mentioned on previous slides. We also think this can be quite useful in understanding ripple effects or unintended consequences of implementation strategies. We often think that our efforts are good and pure and without harm, but we know that implementation efforts can lead to things like emotional labor, data gaming, treatment counterfeiting, administrative burden, opportunity cost, and a number of other potentially negative events. It can also lead to positive unintended consequences. So things like job retention, improving treatment as usual, or even the use of evidence-based intervention strategies with friends and family or for self-care. But we think thinking mechanistically can actually help us to anticipate what might be seen as ripple effects or unintended consequences. This is work that we recently published in Annals of Epidemiology that focuses on how we conceptualize adverse events in trials related to implementation strategies. And I don't have time to go into this, but this is really, I think, interesting work led by my colleague Chuck Goss here at WashU. And I'll just highlight, this is a fascinating study by, if I'm pronouncing the name right, Catlow and colleagues, on unintended consequences of an audit and feedback intervention. And they produce what's called, in this case, a dark logic model for audit feedback harms and endoscopy using feedback intervention theory. And you can see on this slide a number of really concerning negative consequences to this audit and feedback intervention in this case. I think just a fascinating study and way of thinking about this field. So if you have time, I would highly recommend that paper and learning more. And then for those of you who might be interested in advancing mechanisms related work related to implementation strategies and implementation science, I'll just say that there are 100+ challenges that we needed to deal with in this space, and this is work where we established a research agenda to advance the study of implementation mechanisms, led by or funded by an AHRQ conference series over the years, led by Kara Lewis and I. And we really view this as hopefully not an overwhelming set of recommendations in this paper, although it may appear to be so. I think there are opportunities for many folks to advance work on this area, and it's going to take all of us to improve our knowledge of implementation mechanisms iteratively over time. Guillaume, I promised 2 minutes here. So I mentioned the need for improved specification, tracking, and reporting in the field, as reporting is typically poor, which limits our ability to replicate implementation strategies in science and practice, and ultimately precludes answers to how and why implementation strategies work. So we've suggested, this is a paper led by Nola Proctor, Curtis McMillan, and I, where we suggest that people name implementation strategies, hopefully using terminology that's established in the field. One way of doing that is to use things like the ERIC compilation, the behavior change techniques, or other compilations of implementations or taxonomies of implementation strategies that you find relevant to your work. To also operationally define each strategy and any discrete component, and then to specify those implementation strategies. Who are the actors involved in those strategies? What specific actions are they taking? What is the action target? So are there specific constructs that are being addressed by the implementation strategy? And this really sort of gets into the mechanistic thinking that I've highlighted on previous slides. Is there anything about the timing or dose of the implementation strategy that are important to report? And then what are the outcomes that your strategy is ultimately hopefully achieving? And then what is the theoretical, empirical, or pragmatic justification for why you selected that implementation strategy? And we think that reporting implementation strategies and any discrete components using these methods will really help to enhance our ability to replicate other implementation strategies. And to the extent that you utilize open science principles and make materials involving implementation strategies available to others, I think it will really accelerate our understanding of implementation strategies over time. Of course, our implementation strategies may change as contextual changes happen. Things like COVID, other policy changes, other changes in the environment may necessitate changes to implementation strategies, whether we like it or not. Hopefully, this is allowable within the study design that you're using, and if not, hopefully, if it's an implementation practice effort or other implementation-related effort where these changes are allowable, hopefully you describe any planned changes and track implementation strategy use over time as new barriers emerge. And there are a number of methods used to do that. The references below here represent both methods to do that, and I think efforts to make that more pragmatic over time. And I think for the sake of time, happy to move to discussion. I'll just leave with this slide by Luke Wolfenden and colleagues, who I think have a really nice paper on conducting randomized implementation trials. I know I didn't get into trial methods too much here, but this is a nice sort of intro to implementation science as well as implementation trials if you have time and interest.
Thank you so much, Byron. This was a masterclass on implementation strategies, and I'm not surprised you're such an amazing speaker. We have one question in the chat, so you can ask questions with the Q&A function. I'm going to start with the first one. We have about 20 minutes per question, and I also have a few questions of my own, so we can discuss some of those as well. So the first one, I guess, is around how do you account for healthcare systems when planning and delivering interventions, and thoughts on ensuring sustainability and how you think about sustainability when selecting implementation strategies?
Yeah, so I may need a little bit of help on the first part about accounting for healthcare systems and what was meant by that. So if you ask that in the chat, feel free to unmute if that's possible, or clarify in the chat. I mean, one of the things is that that I would say that might seem kind of generic, but you often hear like implementation science is all about context, right? And that's a bit cliche. But I think in terms of accounting for health systems, I think doing your due diligence and really understanding the unique features of different healthcare systems in the U.S. an expression used to be like, if you've seen one VA hospital, you've seen one VA. You know, like there are really differences across, even in systems that are meant to be relatively uniform and unified. And so I think the idea of, as I said, really trying to think about who is influencing and who is influenced by implementation efforts, and engaging a wide variety of partners to understand the features of a healthcare system that might be driving the implementation problem, as well as features that could be leveraged as we think about implementation. And I think maybe we too often jump quickly to solutions and implementation strategies without having a rich understanding of the problem. And so that might be one thing I would say on that front. I suppose to the sustainment, how do you think about sustainment and sustainability? I think this also will sound cliche, Guillaume, but sorry, not sure who asked the question, but I think there's increasing focus on, like, how do we think about sustainment earlier in the process? So even as we're designing interventions that are more likely to be implementable, sustainable, and the like. And so I think there are a variety of pushes in the field to consider implementation earlier and earlier in the process. Some of that is through approaches like user-centered design or human-centered design, or human factors engineering, whatever you refer to that as in your domain. It also includes things like hybrid effectiveness implementation trials, where we're beginning to assess implementation factors earlier in the process. But I think part of that, I think for the field, means designing interventions that are not as expensive, not as clunky. Again, not sort of falling into the trap that we need the kitchen sink for interventions and implementation strategies, because I neglected to say on that slide that there's increasing concern with our implementation strategies that we're sort of designing things that are never going to be feasible long term, and maybe are only feasible because we have research funding or other support available to us as we're studying something. And so I think streamlining and optimizing our interventions and implementation strategies is a real priority.
Thank you. And the context for the first question in terms of the healthcare system was about, public system versus private versus hybrid. So I don't know if you want to add anything, but I think you covered some of that already.
Yeah, I don't think I'll add anything, but yeah, it's a great question. Thank you. And thanks for clarifying.
Great. So the second question is about the use of the CFIR, right? So someone says, I've been using the CFIR to identify implementation determinants. And as far as we understand, when doing the CFIR-ERIC matching using the CFIR-ERIC matching tool, we can only match the barriers identified to the ERIC strategies. Could you give us thoughts on how we can kind of bring in the facilitators that we have also identified in the process in the CFIR-ERIC matching?
Yeah, so to make sure I understand the question, meaning that there are some facilitators that are not necessarily included in the CFIR, or?
So I think it would be more around, they've been focusing on matching strategies to barriers, but they've not really considered in the exercise how we bring in the facilitators in the process. So if you have any thoughts on how to leverage facilitators in the process of choosing strategies.
Yeah, and maybe a concrete example would be helpful. I mean, I think so. So one thing is, sometimes conceptually, I think of barriers and facilitators as like two sides of the same coin. So sometimes we have like an organizational culture that's really healthy and ripe for implementation, or a strong implementation climate. Other times we have a terrible implementation climate. So that could be a barrier or a facilitator, depending on how you think about that. In other cases, you might be thinking about facilitators that don't fit well within the CFIR. But I think to the extent that you can leverage strengths, obviously, that's a beautiful thing. You may or may not need to use an implementation strategy to further bolster a contextual facilitator, or you might sort of ask questions about how and why we can maintain or even improve an existing facilitator in that sense. I mean, the other thing that I would say, and forgive me if this is a tangent to your question, is that I mean, I wouldn't get too caught up on like the matching tool and like maintaining complete precision there, like if it doesn't fit. So I think these things evolve over time. I often say that even if you find something like the C4ERIC matching tool helpful, that it's just a tool. And so I think thinking towards the end of my presentation where I talked about the mechanistic thinking, I think for all of these, it's sort of like asking questions about how and why we might address a determinant, how and why we might improve or maintain a facilitator is important. And so you may have things that don't fit in the CFR at all, or strategies that don't fit in ERIC at all. And going through that process, I think, can still be useful. So don't feel sort of I hope you won't feel constrained or hampered by the tools in that case.
Right. Thank you. We have a question from Dr. Sylvie Lambert. So she's saying, getting buy-in for the implementation of a new innovation is already often challenging, bringing a new clinical intervention in an organization. But then we often need additional buy-in to introduce more implementation strategies or introduce the implementation strategies around the innovation. So do you have any thoughts on how to get buy-in resources around the implementation strategies? How do you present strategies to clinicians, kind of that part?
Yeah, I mean, I mean, a couple of thoughts. I mean, one is, again, a lot of this work is really moving into or would benefit from participatory approaches. So one is sort of this idea of like I don't want to get too caught up in the buzzwords, but like co-creation or participatory development of implementation strategies. I think a lot of the systematic methods that I've shared on these slides and some that you can go back to, I think are sort of undergirded by that approach. So for me, that means like not necessarily coming in as researchers and saying like, hey, we want to try this implementation strategy and we know exactly what it's going to look like. Admittedly, sometimes that might be the case. We might have an interest in a particular implementation strategy, or we may have a strategy that we've developed over time that we're testing in a variety of trials. And so I understand that we're not always coming in with like a blank slate and looking for suggestions. But I also think that we can engage our partners to either to refine those strategies for their settings, or to really come in with a curious and humble mindset in terms of like how we might best implement here. I think, and I think this is not satisfying, but I feel like it's a messy, in a lot of the studies that we're doing, like it's a messy process in terms of how do you get people to consider evidence, the theory stuff, like what's pragmatic. Like I think that's all an interesting dance. But so that's one part of what I would say. The other thing I was thinking is when you asked the question is like, I think sometimes it's interesting to try to present and think about like how much effort is wasted on things that are not going to be sustained, are not going to be implemented well. Like, and so in terms of getting buy-in, I think like, to me, that can be part of the sell, is saying like, if we want to do this right, like we're going to have to invest in it and really trying to get people on board from the outset of saying like, how can we best do this? And sort of like, if something's worth doing, it's worth doing right kind of thing, I think can be important. Yeah, that's a great question.
Yeah,
and Guillaume, you might have other thoughts. I don't mean to. That's a potentially wide-ranging question.
I know. I'm not speaking today. You're speaking. I'm not interfering with the process. Okay, I'm going to bring in one of my own questions. So you've done a lot of work on implementation strategies. You've developed the ERIC taxonomy, and it's been adapted, refined, and so on. Curious to know, do you have any favorite implementation strategies, or strategies do you feel like, looking at the range that you've identified, are underused, that we should kind of, think about more when we develop different projects?
It's an interesting question, and I'm not sure I'm going to stand by this answer after this is recorded and presented. But I'll give a couple of answers. So the first is sort of like something similar to like model and simulate change, which I think can be operationalized in a number of different ways. So I have that paper in there from Gracelyn Cruden on group model building. I have the sort of oilcloth session thing. But I think the idea of like these participatory approaches that get people together to really think and strategize about what the implementation plan is going to be, I think is probably a favorite. I also lean towards these more like inherently adaptive or tailored approaches. So whether it be like a broad approach to tailoring strategies, or something like facilitation, which might be overused in some ways, but I think one reason to like strategies like that is that they are inherently adaptive, and so we can think about what are the characteristics of a good facilitator, how, you know, and I think refining sort of the core functions of facilitation, but really seeing that as an adaptive approach that can work in a lot of different settings, because I think implementation is a lot about sort of like generalizable processes rather than like this locked in strategy that's going to be delivered exactly in this way every time. So I think I'm drawn to more of those sort of adaptive, flexible strategies the most.
Thank you so much. So there's another question in the chat pertaining to Annette Boaz's review, right? The umbrella review of reviews that you've presented. So what do you think about, essentially they're asking, you know, maybe about additional thoughts about the paper around, I guess, the finality and their conclusions, whether or not we do need more reviews of implementation strategies or not. Do you think we have sufficient evidence? What do you think about that?
That's an interesting question. So I guess like to the last part, do we have sufficient evidence? Like, of course not. We need more and better evidence. I think maybe one of the reasons why I sometimes wonder if we need to do reviews, and like, you know, sometimes have colleagues or mentees that are interested in reviews in a certain area, and sometimes it might be like, you know, this specific clinical area, we need to understand implementation strategies in this specific clinical area. And I can kind of anticipate that what they're going to find is that like strategies are not reported well. There's not good reporting of context. We don't understand how and why they were using those strategies. We don't even know what they did because they weren't reported well enough. You know, like all of those kind of common pitfalls of reviews. And so I'm maybe sometimes a little bit more cynical that we're going to get a lot of new knowledge out of reviews in that sense. That's one part. So one part of that is like, can we conduct better primary studies where we're clear about what our strategy is, how and why it's supposed to work? Can we report it in detail? Some of those things that I suggested in my talk. The other part of that is that, like, I think we're interested, and we've talked a bit and seen some interesting work on you know, different types of reviews. Like, it doesn't have to be a realist review, but is there some other kind of like mechanistic review where we're looking not just in like a Cochrane sort of strict systematic review meta-analytic manner at strategies, but are there methods that can be brought to bear to better help us understand those contextual elements and more about how and why strategies work? And I think more of those reviews might be more helpful in guiding our practice and future research. So it's probably a matter of both developing or applying, you know, relevant review methods that can be more informative and improving the quality of primary studies.
Great. Yeah, that makes a lot of sense. Okay, so I'm going to ask a final question, and then I think we're going to be up to time. So common challenge in implementation science is really, and I'm sure, Byron, this must be coming a lot in the talks that you give, is balancing the need for, you know, rigorous evidence-based strategies, developing the strategies, taking into account the local context, and balancing that with the practical constraints of time, resources, of the settings, and so on. So given your experience, how do you go about this trade-off and managing this trade-off between the two? Are there ways where we can accelerate the process or increase speed, efficiency of selecting strategies?
Yeah, so I guess my first answer is that it's always easier to talk about and gripe about methodological shortcomings and people aren't systematic and they're not doing a good job about X, Y, or Z than to actually conduct any study. And so honestly, in my work, like and in work with colleagues, like it's not always ideal, right? And sometimes you're cutting corners here and there. Shouldn't say that on a recorded webinar, but like this happens. Like study timelines are what they are, and so sometimes there's satisficing with all of these things. I think to your point about like rapid methods, like I mean certainly there's a push for like rapid qualitative methods. Alison Hamilton and others have led the way on those approaches. I think again, hybrid studies, other methods that sort of help us get to where we're going quicker with respect to implementation knowledge can be helpful. But it's a great question, and I appreciate the question in the sense that it's an opportunity to say, like, what's the expression? Those in glass houses shouldn't throw stones. I mean, it's dangerous sometimes with this more methodological critique that that it's easy to throw stones when in reality these things are difficult for all of us, and I think there are opportunities to improve, but good to be humble on that front as well.
Great. Thank you so much, Byron, for the talk today, for the discussion. This was fascinating. We're going to be distributing the recording to all attendees. And if you're okay as well sharing slides, Byron, would we be okay with that?
Yeah, happy to.
Okay, fantastic. And then the next session that we're going to have is on April 17, and we're going to be with Dr. France Légaré, who's a Tier 1 Canada Research Chair in Knowledge Translation and Shared Decision Making at Université Laval, and she's one of the leading experts on how to scale health innovations. So once it's been implemented in one or a few sites, how do you go about scaling that to multiple sites? So she's going to be sharing the latest evidence around those approaches for scaling innovations. So I invite you to join that session as well. Thank you again, Byron. This was fantastic, and I hope to see you soon. Thank you, everyone.
Likewise. Thanks so much.
Bye-bye.
Take care.